Good morning, and thank you for being here on Tuesday, which is one more day left for the House of Delegates. This session is the SNAP Talk, DBS, VNS, and ICDs. I'm the moderator, Dr. Kumar Belani, and thank you to the speakers who are here. So Dr. Atul Gupta, I'll be introducing the speakers. Before we start, he's an assistant professor, Department of Anesthesia at University of Chicago, went to the All India Institute of Medical Sciences for medical school, and is board certified in general peds, anesthesia, as well as pain medicine. His clinical interests are ambulatory care, regional anesthesia, and NORA, and research interests of querying very large databases, and will discuss deep brain stimulators. Our next speaker, Dr. Jia Ha, is an assistant professor of anesthesia and critical care, U of Chicago, associate chair for clinical affairs, departments of anesthesia and critical care, and clinical director of the Department of the DCAM operating rooms. And she will discuss vagus nerve stimulators. Our last speaker, Dr. Melinda Searing, is clinical professor, Department of Anesthesia, University of Iowa, and is clinical director of the ASC, program director in regional anesthesia and acute pain medicine, and she's the interim director of the regional program and is on the board of directors of SAMBA and ASA. Welcome, and she will be talking on subcutaneous ICDs. We now start with the first speaker.
Thank you, Dr. Belani, and thanks everyone for coming onto this ultimate day of our ASA meeting. So I'll be talking about the DBS. So these are my learning objectives. I will describe the indications for placement of DBS and components of DBS, assess interaction of DBS with other devices, formulate a plan for caring for patients with DBS presenting for surgery. I would talk about indications, components, why worry about DBS in perioperative period, DBS interaction with other devices, perioperative plan, and finally conclusions. Coming to indications, so the DBS was first approved in 1997 for Parkinson's disease, and more than 200,000 have been implanted worldwide. These 5 indications, which are mostly related to movement disorders, are approved by FDA. And there are many other investigational indications, including chronic pain, major depressive disorder, addiction, cluster headaches, and even obesity. So let's talk about the components of DBS. You can think of DBS as similar to your pacemaker or defibrillator. It has an impulse generator, which is in the subclavicular region generally, or it can be in the abdominal region. There is an electrode which is placed via burr hole in the nuclei, subcortical nuclei, and then there is an extension wire. So the schema is very simple if you look at it, and this is what it looks like. You can see the impulse generator, the extension wires, the leads, as well as the electrodes. But there are 3 manufacturers, and there are DBS placements in which there are components from different manufacturers. Patients may have abundant systems or partly explanted system, and patients may have multiple IPGs. As you can see on the left-hand side in the cartoon, this patient has 2 IPGs, and on the right-hand side, the patient has 2 leads but 1 IPG. And furthermore, the older systems are magnet responsive. There is a reed switch which can be turned on and off with the handheld magnet, but this has been discontinued since 2009. And furthermore, some of the DBS devices have surgery mode or MRI mode, but it's not there in all the models. So why worry about DBS in perioperative period? It is to do with electromagnetic interference with other devices. If we think of other devices as emitters, they can generate unwanted currents in the receivers, which can be radiative due to radio frequency waves. It can be inductive with moving magnets, which can cause current induction in coils, or it can be conductive, which is direct transfer of physical across physical connection. And the electromagnetic interference depends upon the properties of the emitter, the distance between the emitter and the receiver, properties of the receiver, including shielding and presence of wire loops. As I mentioned earlier, there are additional complexities which contribute to EMI risks, which includes compromised integrity of DBS. There can be change in impedance, which can either mean that there's a short circuit if there's low impedance, or there is a fracture in the lead, which can cause high impedance. And both are not good for patients in terms of exposure to EMI. There can be components for different manufacturers and multiple DBS systems, and there can be abandoned or partially excluded systems. So how do the risks manifest? Broadly, the DBS can interfere with the integrity or function of other devices, which can cause inappropriate activation or artifacts, or other devices may interfere with DBS integrity or function. It can cause heating of lead tips, which can cause brain damage. Heating of IPG cause skin burn, can cause permanent damage, in which the DBS can stuck in either surgery or MRI mode. There have been case reports of patients receiving a subtle jolt because of change in DBS stimulation because of EMI. There can be inadvertent activation of DBS if the device is already turned off. There can be reprogramming to factory settings. And finally, a theoretical risk of DBS leads displacement. So how to minimize EMI risk during surgery? These are the very broad recommendations that the turn off the DBS if possible and use surgery mode if it is available. And before turning off the DBS, always dial down to the lowest settings because it can inadvertently turn off because of EMI. Keep the extrinsic current path away from DBS IPG. Position the EMI source more than 15 centimeters away and use the lowest possible energy for other devices and use bipolar mode if possible. The key message is that you cannot just put a magnet and go, because simply most of the DBS IPGs are not even magnet responsive. So let me just go over some interaction with the devices. These are the devices. The devices in red are the devices in which there are case reports of interaction of DBS and these devices. And lithotripsy is one where there is analogous literature from other IEDs. So diathermy is contraindicated in patients with DBS because of these two case reports which led to death or permanent damage. And the patient who died was receiving diathermy after a dental procedure, and the patient who had permanent damage had some spinal diathermy procedure. MRI also is conditional in patients with DBS because of risk of permanent damage. Older devices, it's MRI unsafe. The newer devices are MRI conditional. The condition depends upon the strength of the MRI, the duration of MRI, and what body part that needs to be imaged. So it can only be done if safe conditions for scanning have been met and after involvement of patient neurologist or radiologist. So it is something that may not be feasible in ambulatory surgery setting if you do not have any information about the neurologist or the radiologist who's going to be performing the procedure. Surprisingly, ECT has been reported to be safe in patients with DBS. It turns out that in phantom model, the current just gets directed away from the DBS leads, and there have been 22 case reports which have found no adverse effects. The general recommendations are to place the ECT electrodes away from burr hole, direct the ECT current path away from the DBS, and use lowest possible energy for seizure induction. Coming to pacemakers and ICDs, with the ICDs, there have been 6 case reports. There was only 1 case report in which an ICD shock at 34 joules caused DBS IPG to reset. But there have been no interactions reported with subcutaneous ICD or with pacemaker. There was 1 case report of possible DBS stimulation which resolved after the DBS IPG was resited in pacemaker, in 1 case with pacemaker. So if a patient has a DBS and they are coming for placement of a CIED, the recommendations are the CIED should be programmed to bipolar sensor mode. If magnet is used for CIED, it should be kept away from DBS IPG For models earlier than 2009, the CIED IPG should be implanted more than 20 centimeters away from DBS IPG. And when you're trialing, trial DBS to maximum tolerated setting and CIED to maximum sensitivity. This will ensure that in worst case scenario, the patient doesn't get inadvertent adverse effects. External defibrillators, there have been 2 case reports of IPG depletion and partial dysfunction. Again, the recommendations are to position paddles away from DBS, use lowest clinically appropriate output setting, and check DBS function after defibrillation. Now, there are 2 types of electrocautery. The one that we use in the operating room is the electrical surgical unit, but this is a heat electrocautery which dermatologists use all the time. This is a handheld cautery in which there is no electrical current that goes to the patient. There is a filament like in an electrical bulb, and that gets heated up. And there is no risk of EMI, but there is only a risk if you are placing it near the IPG of the DBS, which can cause heat damage. Now, with the electrical surgical unit, interestingly, there is only 1 case report in which patient had lancinating pain during monopolar mode, which disappeared when DBS was turned off or bipolar mode was used. And we are all familiar with these recommendations that better to use bipolar mode. And if you use unipolar mode, keep the current path away and a different orientation from DBS path, use minimum setting, and use short intermittent burst. This is pertaining to upper extremity nerve blocks. It is, the peripheral nerve stimulation can be used if it is used cautiously. DBS can stay on. There have been 2 case reports regarding this. The thing is that you have to keep the needle away from the wires, and you may need an X-ray to look at the path for the wire from the IPG to the DBS electrode. Keep the PNS current path away from IPG and do not place an ultrasound probe over the IPG. In 2023, there was recommendations from American Society of Pain Medicine and Neuroscience regarding RFA procedures. There have been 2 case reports of lumbar nerve neurotomy, and the recommendations were to turn off DBS if possible and keep grounding pad as close as possible to the RF needle. Interestingly, phacoemulsification is a form of therapeutic ultrasound, and there have been 4 case reports about using patients who had DBS. There is 1 case report of patient with DBS was turned off. In other, the DBS was still active. And all cases were safe. The recommendations were that use pulse mode, use cold irrigation saline because during phacoemulsification, the temperature of the anterior chamber increases by 3.5 degrees centigrade, and there is a theoretical risk of heating of the electrodes. Quick surgery and impedance check before and after. Now, DBS can also cause artifacts in EKG and processed EEG, especially when we are using BIS monitors for our patients. If you can see on the right-hand side, at about 8 hertz, there is a purple line, and which disappears once the DBS is turned off. So what should be the perioperative plan? So anesthesia providers must consult the DBS neurologist. You should know about the type, location, and date of last check, especially the impedance check. Check if the surgery or MRI modes are available. Anesthesia providers should know how to turn DBS on and off. Symptom severity when the device is on and off, because since most of these devices are placed in patients with movement disorders, it's really important for the anesthesia provider to know what symptoms patients get, what current medications they are on, and patients should be asked to bring fully charged programmer on the surgery day. If procedures are going to be under MAC or sedation, it needs to be after discussion with the patient, surgeon, and DBS neurologist. Try to keep DBS on if possible. Consider general anesthesia if DBS must be off, and severe symptoms occur if the DBS is off, and recheck DBS after the procedure is done. If the procedure is under general anesthesia, turn the DBS off or place in surgery mode right before or after GA induction. Take usual precaution against against EMI. May need to turn on DBS before emergence to assist in arousal. There have been 2 case reports in which patients did not wake up even after the gas was off, and once the DBS was turned on, the patient just woke up. And these are very interesting case reports. And make sure to check the DBS after the procedure. In February 2025, this was an APSF newsletter in which there was this whole review article about perioperative neurological stimulator management. And this covers most of the topics that I have already outlined. So conclusion, it's critical for anesthesiologists to understand EMI risks. Careful perioperative planning is essential to prevent device or patient harm, and you cannot just put a magnet on it and go. Thank you.
I think we'll do the questions after the third speaker is done. So now we can move on to the next speaker. Is that, yeah? Yeah.
Hi, everyone. My name is Ji-Hye Ha, and I have the privilege of speaking to you today about the management of vagus or vagal nerve stimulators in an ambulatory setting. The learning objectives for the talk include first describing what vagal nerve stimulators are, how they work, and what they're used for. Next, we'll learn about several important side effects or risk factors associated with VNS, which may impact perioperative care. And lastly, how these considerations apply to the management of these patients in an ambulatory setting. So let's start off with the history in terms of the timeline of vagal nerve stimulators. So vagal nerve stimulation was first described in the 1800s for its effect on the suppression of seizures. The theory at the time was that seizures were caused by cerebral hyperemia, and thus carotid compression was actually used as a treatment for seizures. A neurologist named James Leonard Corning developed two instruments to compress the carotid arteries. One was a fork-like device called the carotid fork, and another one was an adjustable belt that would encircle the neck for the same purpose of carotid compression, but worn for seizure prophylaxis. In 1884, he combined carotid compression with transcutaneous electrical vagal nerve stimulation with the intent of stimulating the efferent vagus nerve pathway to slow down the heart rate and decrease the cardiac output, and thus to decrease the cerebral perfusion. As you can imagine, these treatments were very inconsistent, was not widely adopted, and abandoned for another 100 years before finally in 1988, after many other animal studies, the first VNS device was implanted in a human. The Livanova VNS, formerly Cyberonics, was approved by the FDA in 1997 for the treatment of refractory or drug-resistant epilepsy. 8 years later, VNS was also approved for the treatment of adjunctive treatment for difficult-to-treat depression. And in 2021, the Vivastim VNS was approved for the use in stroke rehabilitation. And most recently, as of July 2025, SetPoint Medical VNS was approved for the treatment of moderate to severe rheumatoid arthritis, not adequately managed by current therapies such as biologicals and other disease-modifying anti-rheumatic drugs. There are several other indications under investigation, ranging from obesity to other neuropsychiatric disorders, and even heart failure. So you can imagine, how can VNS be so useful for such a wide variety of medical conditions? But let's first talk about the actual device itself. So VNS therapy involves intermittent electrical stimulation of the left vagus nerve. Surgical implantation involves the placement of a pulse generator on the left chest, either subcutaneously or subpectorally. An electrode lead is tunneled and attached to the vagus nerve with 3 spiral coils, with the middle one being a tethering coil. And the entire procedure takes approximately 60 to 90 minutes and can be done in an ambulatory setting. So an electrical pulse is produced by the pulse generator, flows down the lead to the vagal electrode array, and stimulates the vagus nerve. More specifically, the left vagus nerve is used instead of the right vagus nerve based on the innervation of the sinoatrial node as to minimize the risk of bradyarrhythmias. And this is generally how all the various VNS devices are implanted, except for the newest VNS for rheumatoid arthritis. So the set point system for rheumatoid arthritis is a very small integrated neurostimulator enclosed in a silicon pod and placed directly on the left vagus nerve. The advantages of this device, aside from the small size, is that in comparison to the traditional VNS, it minimizes the manipulation of the vagus nerve itself since you're not having to wrap around the coils. There's no electrical lead, so there's no tunneling involved, and there's no IPG on the left chest. Furthermore, it's rechargeable using a wireless necklace-like charger, as you can see on the image, with a longer battery life of up to 10 years in comparison to 3 to 8 years. These improvements alleviate some of the adverse events related to the traditional VNS, such as the potential for lead fractures, scar tissue formation, and the need for more frequent battery replacement. So how does VNS actually work? So the precise mechanism of how VNS works is unclear. However, we understand that the vagal afferent pathway relays input to the nucleus tractus solitarius, which then has multiple projections to higher cerebral centers, including the locus coeruleus, amygdala, thalamus, and the hypothalamus. And this may in turn lead to modulation of neurotransmitter release, including norepinephrine and serotonin, or changing the functional connectivity of different regions of the brain over time. So for epilepsy, there's activation of the locus coeruleus, which releases norepinephrine, and this leads to increasing the seizure threshold. And norepinephrine also plays a role in mood regulation. VNS can aid in stroke rehabilitation by stimulating the motor cortex and increasing its neuroplasticity. So this helps to strengthen pathways for motor learning when timed with rehab exercises. Known as paired VNS therapy, the IPG is programmed to deliver stimulation by the therapist during functional task-specific therapy by usually pressing a button. And then at home, with a device in the magnet mode, the patients have the ability to perform self-activated therapy by simply swiping the magnet over the IPG. This stimulation then lasts for 30 minutes and can be performed up to 8 times a day. VNS also has anti-inflammatory effects through the modulation of cytokine release from immune cells, such as TNF-alpha and various interleukins, thereby reducing the symptoms of some inflammatory conditions such as rheumatoid arthritis while minimizing the risk of immunosuppression. This has been shown to be effective in rheumatoid arthritis, but may also be potentially treatment options for other immune-mediated conditions such as Crohn's and multiple sclerosis, and there are studies ongoing. So the VNS device is programmable and personalized for each patient. The parameters involve output current, frequency, pulse width, and the timing of how long the device is on and off for. Typically, these devices are turned on 2 weeks after surgical implantation, and the starting current is typically much lower and incrementally increased to the target values while adjusting for tolerance. The typical parameters for the treatment of seizures and depression are quite similar, with stimulation every 5 minutes that lasts for 30 seconds in duration. And then newer VNS models for epilepsy have an optional auto-stimulation mode, which senses tachycardia and delivers periods of continuous vagal nerve stimulation. And the reason for this is that tachycardia is seen in 80% of patients while they're having a seizure, and thus with this auto-stimulation mode, it would be potentially able to prevent or abort a seizure if it were to occur. As discussed earlier for stroke rehabilitation, the initiation of the therapist or a magnet swipe across the IPG causes a much shorter stimulation, but can occur more frequently. And lastly, in rheumatoid arthritis, it is programmed actually to be only on for a minute or 60 seconds during a day. And even in this type of setting, studies have shown a reduction in multiple cytokines up to 70%. Patients are strongly advised to always have their own VNS magnet. The top image is the magnet for Livanova, which comes in either the style of a watch or a pager. And the bottom image is of the Vivistim magnet for stroke rehab. So the magnets can be used to deliver an additional period of vagal stimulation when swiped across the generator. So for epilepsy, this would terminate a seizure, whereas for stroke rehab, it would allow for the paired VNS therapy. In all settings, continuous application of the magnet to the device or the generator will deactivate the device. So moving on to perioperative considerations, we first need to consider what are the side effects and risks of vagal nerve stimulation. As we know from anatomy, we know that the vagus nerve also provides the motor and sensory innervation to the larynx and the pharynx, and thus VNS is associated with laryngopharyngeal dysfunction in 2/3 of patients. And these symptoms typically manifest with voice changes, dyspnea, and coughing. In 1% of patients, they may also have vocal cord paralysis, either as a result of surgical trauma, inflammation of the vagus nerve, or repeated vagal nerve stimulation. And furthermore, stimulation of the recurrent laryngeal nerve may cause vocal cord abduction or adduction, depending on the frequency of the VNS. So at 20 to 30 hertz, which is typically the setting for most of the vagal nerve stimulators, it actually causes the vocal cords to abduct. 1/3 of patients with refractory epilepsy are found to have obstructive sleep apnea, which may actually worsen with vagal nerve stimulation. It causes sleep disordered breathing through various mechanisms, which I won't go into. And then lastly, despite the fact that the placement of the VNS is on the left vagus nerve, bradyarrhythmias are still reported, and they result in hypotension, syncope, and rarely cardiac arrest. Most bradyarrhythmias occur during the implantation phase of the vagus nerve when they're testing for lead impedance. However, delayed arrhythmias have definitely been reported. So putting together all of these potential side effects of VNS, this may lead to several factors to consider perioperatively. VNS has been implanted in over 135,000 patients with epilepsy alone. And so one can imagine that there's definitely going to be an increasing number of patients presenting in all forms of surgery, but also in ambulatory surgery, whether it's unrelated to the VNS or for those coming in for VNS management, whether to change the battery, deal with any fractured leads or anything like that. So combining information mainly from manufacturer manuals and a small number of publication in the form of case reports, the Association of Anesthetists published guidelines in 2023 for the management of VNS in the perioperative period. As we know, a preoperative assessment is crucial to understand the indication for the VNS. And if the indication is for epilepsy, as we always do, we need to understand and characterize the type of seizures that the patient has, how well it's controlled, the type of medications that they're on. We must also identify the location of the generator and if the patient was able to bring their own personal magnet. Other things to assess would be the presence of autostimulation and also screening for obstructive sleep apnea. So can you just put a magnet on it and go? Although clinical practice reported in the literature is actually varies in terms of recommendations regarding perioperative device deactivation, the consensus from the 2023 guidelines is that generally it's safer to formally deactivate the vagal nerve stimulator before elective surgery to avoid some of the potential complications that I've already mentioned. However, this must be, of course, weighed against the risk of turning off the device. And for most of the indications that we discussed, turning off the device temporarily won't have large detrimental effects, with the exception of epilepsy. Here are some special considerations when taking care of these patients. Deactivation should particularly be considered in surgical procedures such as laparoscopies, in which there's an increased risk of excess vagal tone. Similarly, with neuraxial anesthesia, there's a theoretical concern of exacerbating symptoms of sympathetic blockade, especially with spinals over epidurals. When performing peripheral nerve blocks, they should be avoided in the ipsilateral upper extremity, and caution should be used when using peripheral nerve stimulators. Postoperatively, whether or not the device was turned on or off, it's very important to, of course, reactivate it and then also to interrogate the device to ensure proper functioning, especially when there's been exposure to electrical current, EMI. And it's important to note that emergency deactivation with a magnet should never be delayed for defibrillation. If that VNS is not formally deactivated, or if the decision is made to keep the device on, a magnet should be readily available to place and to urgently deactivate the device if there's any complications. Any magnet greater than 50 Gauss in strength may be used, and the typical pacemaker or ICD magnet that we usually have is actually 90 Gauss, so that would be sufficient. Due to some of the airway concerns related to vocal cord changes and laryngopharyngeal dysfunction, an endotracheal tube is generally recommended over a supraglottic airway due to both the risk of obstruction as well as the risk of aspiration, especially if the device is left on for general anesthesia. And lastly, autostimulation should be turned off to avoid the inappropriate and excess vagal stimulation that may be triggered either by EMI or the tachycardic response to surgical stimulus. And lastly, if a patient does require an MRI, it's important to note that VNS are MR conditional, but the programming wand and magnets are not. Furthermore, it's important to highlight the unsafe MR exclusion zones, which are part of the body that should never be scanned in under any circumstance. And this varies from the level of C7 all the way down to L3, depending on the VNS model as well as the MRI. Deactivation of the VNS device is recommended, and interrogation with reactivation after. And additionally, no scanning is recommended within 2 weeks of actual implantation as to avoid inadvertent movement of the device. So in summary, VNS has a wide clinical application with more FDA approvals on the horizon. And as anesthesiologists, it's really important for us to understand how VNS works and the side effects that may potentially affect our anesthetic management. And ultimately, the perioperative decision to deactivate or keep the device on should be carefully considered and individualized. Thank you.
We now go on to Dr. Searing. Talk on subcutaneous ICD.
Hello, I'm Mindy Searing. I'm from the University of Iowa. I'm going to start first by seeing if anyone has actually encountered any of these subcutaneous AICDs in your practice or heard of them at all. That puts you pretty close to the people I had dinner with last night. So we had a long discussion about it last night. So as here, I'm going to start with what actually it is, for those that haven't seen it before, and then we'll talk a little bit about the indications, a little bit about the history of implanted cardiodefibrillators. We'll talk about the difference between our traditional transvenous defibrillators as opposed to the subcutaneous ones, and some benefits and limitations of what the subcutaneous one is, and then we will proceed to how we're going to manage those when they show up to our ambulatory surgery center. So first, let's talk about what it is. So this is a subcutaneous AICD is a less invasive implantable defibrillator placed under the skin, avoiding the need for any leads to go into the heart. It consists of the pulse generator, which is placed laterally about mid-axillary line on everyone, and then it's tunneled into this area along the 6th rib and up the breastbone that you can see here. So you can see here's your battery pack, you're tunneled here, and then you're tunneled up here. And I'll show you a picture of the tunneling here. So you can see you do this in an ambulatory setting, and they're tunneling right under this breastbone, and then they just tunnel. It goes between the breastbone and the heart, where it's replaced, or it's placed right there. It's important to note that this is not a pacemaker. This is just a defibrillator for tachyarrhythmias. So it cannot convert, it can only defibrillate. So let's talk about what indications we would do to put these in. So what we're doing is we're treating ventricular arrhythmias basically with this device. So any patient that has a sudden a structural cardiac disease that would cause this, a history of cardiac arrest. The biggest things that you want to consider the sub-Q versus the transvenous are for congenital diseases that make vascular access hard. So traditionally we access the heart vascularly and place these leads, but if you can't get into those vessels, this is an alternative for it. Any lead infections or lead disruptions that the person has had in the past, they may be a benefit from this subcutaneous approach. Any coagulopathies that would prevent you from being able to go into a vascular access for those patients. These are monitored the exact same way the transvenous AIC are done. So patients can either have a bedside transmitter that sits there and can transmit a monthly report, or they can have a smartphone app that can transmit the report. It's important to know that you need to have internet access in order for this to be done effectively. So people living in the rural area, people living with spotty internet access may not be able to do this monthly, and it may have to be set up that they go to their primary care provider to get this sent to them. The nice thing about this is, as it's sent monthly, it can alert the cardiology clinic if there's any concerns, any battery concerns, any inappropriate defibrillations that are happening to this patient. The patient can also initiate their own report. So if they're feeling like they're having palpitations, but they're not getting a defibrillation, or they're getting defibrillations where they don't think they should, they can initiate this report as well. And then also important, just like our traditional transvenous ones, we need to go in every 6 months and have a thorough interrogation with our cardiologist. So let's talk a little bit about the history of AICDs in general. So it was about 1960 before we had anything even thought of having an internal cardiodefibrillator. Prior to that, any ventricular arrhythmias, any synchronizations had to be done with external cardiac devices. Dr. Morton Maurer had a friend who passed away because they were unable to get the external defibrillator to him soon enough. So about 1960, he started to do research on this with Dr. Michael Morawski. They started making prototypes from the very large external defibrillator down to smaller and smaller sizes, experimenting on animals. They finally partnered with a Medrad company to make a prototype. The prototype was probably about the size of a deck of cards at that time. And then in 1980, they did the first implantable AICD at Johns Hopkins to a 57-year-old man. At this time, it was done with open heart surgery, so you had to physically be open. Leads had to be implanted directly onto the heart at that time. Advances were made. The battery pack started to become smaller and smaller. In 1987, so 7 years after the first open heart, that's when they discovered that the thought was to try this transvenously. So they tried the femoral vein and to implant that first venous leads in those patients. And that's what we continued with for some time. In about 2000, it was noted that patients started dying from lead failure from ventricular arrhythmias in these traditional wired AICDs. And so about 2002, there were pilot studies that began in Europe and New Zealand looking at implanting a subcutaneous AICD in patients. 2008, the European Society approved the use of the subcutaneous AICD across Europe from a 52-patient study pilot for them. And then in 2012 was the first time the US approved that through our FDA. So let's talk a little bit about the differences. I've alluded to them, but we can thoroughly talk about the differences between our traditional transvenous and the subcutaneous AICD. So as we've talked about, our traditional transvenous one goes up through a vessel, used to be the femoral, now you're looking at right internal jugular or left subclavian vein that those leads are implanted into the heart, and then the battery pack is placed into the pectoral region, generally on the patient. These generally can provide pacing, they can provide cardiac resynchronization, and they can provide defibrillation in patients. The biggest risk to these are lead-related issues. So leads can become dislodged, leads can become frayed, leads can become moved on the patient. The subcutaneous AICD that you see on this patient, again, the lead is placed under the skin. There's no wires in contact whatsoever with the patient. But again, it's used only for defibrillation. You can't pace, you can't resynchronize on these patients. The battery lies in the axillary line. So a little different than laying in the pectoral region, but if you have someone that's moving their arm a lot for work, this can cause a little bit of irritation and trauma, and it can be bothersome to people as well. So let's talk about the benefits and the limitations of the subcutaneous AICD. So benefits-wise, as I've alluded to, there's less risk of lead-related issues. You don't have a lead, so there's no risk of breakage, there's no risk of infection, there's no risk of dislodgement for these patients. It's a less invasive procedure. These are simply done very quickly in the cath lab, minor sedation on these patients, sent home very quickly. Low risk of endocarditis. We're actually not going into the heart on these patients, so you don't have to worry about a risk of infection in the heart on those patients. And there's a lower risk of bacteremia. Again, we're not going into a blood vessel. So lower risk of infection in those sites, and not a lot of reports of infection from this like you see from our pacemaker pouches that you see. But there are risks associated with it. Besides the fact that it doesn't resynchronize and it doesn't pace, you can get lead erosion. So you still have, even if it's not a lead going into your heart, you still have a lead connected to a battery pack. So that can still come dislodged there, and you can see it erode through the skin as it's shown in this picture here. Bruising and hematoma, obviously, you're tunneling under the skin on patients, so that it could cause quite a bit of bruising and hematoma. The cosmetic appearance, which I've alluded to, so if you have a very slender person, that battery pack is going to sit out quite a bit. And again, if you have a physical laborer that's moving their arms, that pack is going to be hit quite a bit when you're moving your arms up and down. Always a risk of infection when we go in. It's got a shorter battery life than the traditional one. Again, replacing it is fairly easy by replacing the battery pack, but it does have a little bit shorter life. And then there are chances of it over-sensing. So you don't have leads in the heart. Physically sensing, it's got a connection over the top where it's programmed. So you have people that can go into tachyarrhythmias that are not fatal ventricular tachycardias, and it can cause an inappropriate shock. Because you can't pace and you can't resynchronize, there are people that combine the subcutaneous AICD with a wireless pacemaker. So this is a tiny battery that has very tiny electrodes placed that are on the device that can sense heart rhythm and deliver impulses. They don't defibrillate, but it's pretty small. It's about the size of a nickel. It's in there. So transvenously, this is implanted into the right ventricle, as it's shown in this picture here. But there are no leads that go into the heart. It's able to sense, and it's able to give impulses as you need to. There's no MRI interference at all with this, so patients can have an MRI if they have this in place. Very fast recovery from this. Again, no battery pack, so very good cosmetic appearance for patients. This has a battery life of about 12 years. So if the battery were to expire on this, which I found interesting, they leave that in place and they re-implant another one right in there next to it. But because it's so small and because we can't see it, in order to go to the operating room, you have to have this interrogated every time before you go in the operating room. And if you're having surgery above the umbilicus, where we would normally worry about interference, you would have to have that reprogrammed and then reprogrammed at the end as well, too, because there's no way to put a magnet on this particular site. Okay, so let's talk a little bit. I've talked a little bit about the management of the wireless pacemaker, but let's talk about the management of a subcutaneous AICD. And I just put this chest x-ray in because sometimes our cardiology doesn't have good notes exactly where our pacemaker is and what it's doing. So if you see a chest x-ray where your battery pack is here, and then you can kind of see the leads come up here, then you know that's a subcutaneous one versus seeing it up in the chest. But you're going to do the same thing we do for most AICDs. We're going to check to make sure there's a recent interrogation. You don't worry so much about impedance in this because there's no wires, but you're going to worry about battery life, and you're going to look at how often the defibrillators had to be used in this patient. You can't easily place a magnet on the side of a patient. So we have a nice shelf here on our pectoral area where it's easy to put it on and tape. It's really hard on the side, especially if arms get tucked or things are getting moved around in the surgery. For us, we do a lot of breast surgery, so this would be kind of an interference in our situation, or even shoulder surgery. So you need to know kind of the location of surgery. Again, if it's above the umbilicus is where we worry about having to reprogram it and do something. If it's below the umbilicus, you don't need to do anything for that device. You need to know the cautery as well. Are they using monopolar or bipolar? So similar that was talked about with our DBS, you want them to use bipolar. You want them to use short bursts. You want to make sure that your cautery patch is placed so you don't have a large arc over where you know that lead is running in the heart. And the important thing is if you have to turn this off, put defibrillator patches on the patient when they're going back into the operating room, because if they have this defibrillator, they obviously need it for a reason. So we want to make sure we're prepared to treat that in the operating room. And then when they leave the operating room, you want to make sure you get it turned back on. So don't turn it off and forget to turn it back on. Again, it's fairly easy if you're in an ambulatory surgery center like I am, because I'm attached to the hospital. Cardiology comes over right away with EP and does it. But when you're in a freestanding, you need to probably get the vendor over for that particular device to turn that off and turn that on for you. And that is it. Thank you.
Thank you. The floor is now open for questions. Anybody? Looks like everybody understood everything. Oh, come on.
How effective
You wanna?
is this subcutaneous AICD compared to AICD in terms of defibrillation?
Yeah, I mean, I think the battery pack, I don't know if this is on. The battery pack has the same infective ratio as the pack, probably a little less, because just sitting up in this area tends to get a little bit more stimulation in here than the side. But the actual leads itself are very low. I haven't seen any in our institution or reading case reports that have shown the actual tunnel lead having much of an infection source.
No, not the effectiveness.
Oh, the effectiveness. Yeah, I mean, I'm sorry, I misunderstood you. The effectiveness for defibrillating ventricular arrhythmias is about the same. But again, remember, it doesn't pace and it doesn't cardiovert. But for young people that had a cardiac event, it's used a lot in those young people. It's a little bit better, no leads you have to worry about.
So, Dr. Gupta, for these deep brain stimulators, there are lots of indications. Is there any evidence to show that the other indications is as effective as it is in Parkinson's?
So, at least for the 5 indications that I talked about, they are FDA-approved indications. You know, dystonia, tremor, which is treatment-resistant, epilepsy. In terms of efficacy, I actually did not go into detail in terms of how effective it is for other conditions. But suffice to say that there are many more conditions that are actually being investigated. And in some conditions, that seems to be the only option, because in many conditions, it has got the humanitarian device exemption from FDA.
Would Alzheimer's be something that it might be?
Actually, it's on the list for the investigational devices.
Okay. Dr. G.A., this for the anti-inflammatory use of this stimulator, because if it blocks the complement pathway, I think there can be many uses for it, even for patients who might be sensitive to peanuts, like, anaphylaxis, right?
Yeah.
What do you think?
It's very possible. It's surprising how such a wide variety of applications for this potential use, which I didn't really know about until I was forming this talk. And pretty much anything with any kind of like immune-mediated condition, whereas it's allergies, eczema, I imagine that this could be a potential therapeutic thing that could be used in the future.
And Dr. Searing, for the subcutaneous ICDs, are they being implanted in children as well as as much as in adults?
I have not seen them going down to small children because of the growth and the change for the leads, but I think once a child reaches that teenage growth maturity that you can place it, but right now they don't have it in the pediatric format.
Now, since many of these patients are going to get more and more of these devices, how do we, as ambulatory care providers, how do we make sure that we have the most accurate information available to us in a timely fashion, and also, have some recommendations as what needs to be done, so that not everybody has to be, up to date with all the newer devices, but is there any way of making this so that it happens automatically? With help of maybe AI or something?
Yeah, I don't know that I can say that AI is working that well at our institution, but we do have a pretty extensive preoperative review process for the patients that get moved to our ambulatory surgery center. And our nurses that start the process for us are pretty cued in on any devices. So I'm sent every device that's installed in the patient. So DBS, hypoglossal nerve stimulator, VNS, any kind of AICDs. I sometimes even get glucose monitors because they're not sure what they're looking at. But I mean, I think that's a cue in for my nurses. And so I'm going through and I'm usually making sure there's a plan for these patients and making sure the patients are bringing their devices if they turn them off themselves.
Yeah. Many times I'll be sitting down with the patients and they'll have the device controller, especially for the deep brain ones. And I get to sit down and maybe spend 5 minutes, 10 minutes to learn how to use it. And then we leave it. If you're going to leave it on, then you know what to do if something happens. and then also whom to call if there's a situation where something is wrong. Not all patients are as knowledgeable about their own devices, but I think that's a weakness in our system where if the patients were given the information and if they could keep that, that would be so helpful. But for some reason, a simple thing like this is not available to us when they come. Anything we can do to make that happen better, like contacting the companies and telling them to give them a detailed, like, handout or something that they can keep available in the cloud for us to look at.
I mean, most of these devices do have patient information and some succinct card that the patient is advised to carry with them. I imagine that it probably would be very feasible to have some sort of QR code that providers could probably just scan and see a quick summary of recommendations for perioperative management.
Yeah. The most I've seen is those with glucose monitors where they have those under the skin. They are very smart. They know exactly what to do because it's an acute thing that can change what's happening, and those kids, even kids, are very smart about that. But I haven't seen that in the case of pacemakers and deep brain stimulators.
Yeah, we have wrote protocols at our ambulatory surgery center for all these devices that are available for any anesthesia provider at our hospital. They can look up and they can go through the protocol and who to call if you have trouble or the patient didn't bring their device to turn it off. So I found that to be very helpful, but our ASC runs on pretty much protocols for everything, so.
Any other questions? Good. Thank you. Thank you for your people staying here, and thanks to the speakers. Excellent.